All right, good afternoon, everyone, and thank you so much for joining us for this month's Teach Educational Rounds. Here with us today, we have Dr. Selby, Dr. Zawertailo, and Dr. Khara, who will be hosting a panel on e-cigarette use and vaping. Before I hand it off to our presenters, I'm just going to go over a few housekeeping slides. If you're interested in receiving a letter of completion for today's Teach Educational Round, please make sure that you have registered for this webinar and completed the pre-learning assessment. You have signed in to view this webinar using your first and last name so we can track your participation. And finally, you have completed the post-learning assessment, which will be emailed to you by the end of tomorrow, and you will have 1 week to complete that. Please note that a copy of today's presentation slides will be sent along with the recording this afternoon as well. Here's a little bit more information on our first presenter today, Dr. Selby. His research focuses on innovative methods to treat and understand addictive behaviors and their comorbidities. This use of innovative methods makes Dr. Selby a sought-after speaker for various topics including addictive disorders, motivational interviewing, and health behavior change at individual and system levels. So we are thrilled to have him with us here today. Here's a list of his disclosures. Our second presenter today is Dr. Laurie Zawertailo. Dr. Zawertailo's research interests are in the area of behavioral and neurobiological aspects of tobacco dependence and treatment, especially in individuals with comorbid depression or alcohol use disorders. Her goal is to understand the neurobiological and behavioral processes involved in nicotine use and addiction, and she is currently the principal investigator of the STOP program. Here is information on her disclosures. Lastly, Dr. Milan Khara is a UK-trained physician currently working with Vancouver Coastal Health. His work primarily focuses on treating tobacco use disorder, but increasingly extends into other areas of tobacco control. Recently, he has led initiatives to combat the growing use of e-cigarettes in high schools, speaking both with educators and students in a variety of settings. Here is some information on his disclosures. And finally, here is some information on our disclosures. Please note that the content of Teach Educational Rounds are centered on evidence-based guidelines from the following sources. These materials, as well as the verbal presentation and any discussions, represent only general principles, and they do not remove the need for clinical assessments or treatment plans by healthcare professionals. Please feel welcome to use the chat feature during today's webinar to provide any feedback or post any questions. We'll be holding a question and answer period following the presentation. To use the chat feature, you can click on the speech bubble icon in the control panel, and please ensure that you select everyone to make sure that the panelists and the hosts can all read your questions. As a note, this feature was previously labeled as all participants. With that, I'll leave it to our presenters to take it away. And now I'm just seeing, oh, perfect. Dr. Selby has come in to join us, so I'm just going to share and pass the presentation controls over to you, Dr. Selby, so you'll be able to control the slides from here on out.
Thank you, everybody. Sorry about that. I'm having difficulty. I was connecting to the wrong section. All right. Is Dr. Khara with us too? I can't see.
Hey, I am here.
Ah, great. Wonderful. Okay, so thank you very much, Sophie, and welcome everybody. As you know, this is based on the questions that you submitted to us, and we have learning objectives that we want to cover. 3 things: examine the current state of evidence around vaping, investigate dual use of tobacco and e-cigarettes, and identify potential vaping cessation interventions. I don't know if did you all do introductions already, Laurie and Milan?
Sophie read our bios.
Oh, wonderful. Okay. So sorry, let's get going, and let's see what the next slide is. All right, did that advance the slide? Okay, there we go. So these are some of the themes. So obviously the questions that came up were the health effects. How many years will it take before we know the true health effects of vaping? and what are the chemical substances in e-liquids? Are they carcinogenic? And how do we provide effective psychoeducation on the health effects with clients? So why don't we start off with the first question, and I'll open it up for you both. What do you think about this? How many years do you think it'll take before we know what the true health effects are?
So, I mean, I think some health effects are starting to emerge. But yes, the true health effects, like we know the health effects of smoking, I imagine it'll take the same amount as it did for smoking. So, you know, a good 25 to 40 years. I don't know. Milan, do you have a different opinion?
I think that's correct, Laurie. I think that's the conventional thinking, that we'll be middle of this century before we have a somewhat full understanding. And it was interesting that that very nice review of the respiratory effects of e-cigarettes that was published in the British Medical Journal last year actually used that language exactly, that it would be the middle of this century before we know the full effects. So yeah, using the cigarette principle, a couple of decades of use will tell us what happens.
Well, but I think there's, if I can add to that, yes, I think those physical health effects that we talk about, harms that come from exposures to the toxic compounds of combustion, absolutely. What I think is known right away is that it is addictive. We have good case examples of, and that's the health effect. I mean, addiction is a health effect. Like if you have young people who cannot function because they can't, if they don't get their vaping device, are engaging in risky behaviors, are hiding it, or prioritizing vaping over anything else because they can't do without the nicotine from that effect is known right away. So I think that's the health effect that we know is happening. Now, whether that's a consequential health effect in terms of, sensitizing the brain to then that person becomes a smoker, or sensitizing the brain so that person now develops some sort of other neurological conditions or depressions or anxieties. Yeah, well, nicotine by its very nature goes in and out of people's brains quickly and can be quite problematic. And so those health effects, I think we're not necessarily fully aware, because the dosing that people can get out of vaping seems pretty high. They can get quite sick from it. So I think those things are known, but you're right. The cardiovascular and the chronic health effects from exposure to something that's been heated or burnt, that's TBD. And then there's the other one, I think, is if you can talk about, there are the health effects of vaping also are determined not just by the nicotine, but the PGVG and then the flavors, right? And so any thoughts about sort of breaking it down into those things? Because some of those can cause acute effects too, right?
Right. So I mean, yeah, we'll probably kind of delve into the second question as well regarding chemical substances and carcinogenicity. So I think, things are obviously, the health effects of other constituents of e-liquids are starting to emerge. And, it started pretty early on with e-liquids and the diacetyl that was in the kind of original flavors of cookie dough and popcorn, etc. And we know what the health effects of diacetyl are in very, very, very high doses. And there were some case reports of this popcorn lung. I think the industry kind of took note of that. And I don't think you can find diacetyl in very many e-liquids anymore. But it is something to obviously pay attention to. The other one is cinnamaldehyde, which is the cinnamon flavor, or any other flavors that contain this cinnamaldehyde has been shown to have some harmful effects as well. So, paying attention to flavorants, especially because, you know, they may be food grade and safe for ingestion, but we don't know what the effects of actually inhaling them are. So these are things that, you know, we all need to pay attention to. We really don't know, again, long-term what the health effects are, but we have been seeing some short-term health effects, certainly.
And Milan, your point.
Yeah, so Peter, I wanted to pick up on your comment actually, and of course we all appreciate that nicotine arriving quickly in the brain through these devices has the potential for addiction and all the negative consequences that go along with that, and that's so central in very much of what we worry about with e-cigarettes. But I think it's not a given that this generation of young people who are clearly experimenting in pretty big numbers with these products will have the same trajectory as the very high number of tobacco users who converted to pack-a-day, lifelong addictive disorders will have. I think we don't really know the trajectory of this you know, high school experimentation with these e-cigarettes. I mean, it's of course reasonable that we worry that they will have a similar kind of trajectory, will become addicted, may convert to tobacco use or may not. But it's worth just thinking about that we're making a lot of our assumptions based on the tobacco epidemic in this age.
Well, there is some emerging evidence about, you know, this switch, that there is a subpopulation that is switching, and we don't know, you can't say it's causative, but it's associated with this issue. And I think Donna has put in a comment there that her son developed cyclical vomiting with vaping. Now, you usually see the cyclical vomiting with cannabis, but nicotine itself, if you're getting too high a dose, that can make you vomit as well, right? It's nicotine toxicity, right? It makes you vomit. So again, I think we have some problems with the products, that they're not regulated, the amount of nicotine. So you could get acute effects like we're talking about. And you're right, the jury's out as to whether it's a gateway drug or not. But and are we pushing people, you know, from vaping to cigarettes, or, you know, are they naturally going that way? We don't know yet. But again, coming back to the carcinogen, you know, clearly that also has to do with the product, right? Depending on how high the temperature goes, are you being able to generate acetaldehydrogenase because you're now getting closer to a combustion temperature as opposed to a heating temperature, you know? So yeah, there is some. I mean, it's a lot lower than cigarettes, but there are, you know, it's not that it's carcinogen free, or there is any device that we can say, yeah, that type of, you know, pod-based system is carcinogen free. They all heat to a certain degree. And what are the carcinogens that they generate? Okay. So, all right. Any other? I think there's some questions again. The oily coating in the lungs, actually, that's very interesting. It doesn't actually come from. I know you want to take that about the THC oil and the E-valleys, and do you want to talk to that?
Sorry, which one of you?
So I think Donna talked about, the question is the oily chemical coating in the lungs. I guess that's referring to the E-valley cases that were reported with vaping.
Yeah, so that's now been shown to be almost exclusively due to contaminated THC pods that were contaminated with vitamin E acetate, which is an oily substance, and that seems to be what causes E-valley. Yeah, I think there's been a handful of cases that maybe it was indeterminate, that there was no THC detected in plasma or urine, and so it might have been a contaminated e-liquid, nicotine-containing e-liquid. But for the most part, it's been shown to be this vitamin E acetate in THC pods. And, you know, the EVALI, I don't know, are there still cases of EVALI? I have not heard of any recently. I think it was a very short term and kind of concentrated in certain areas of the US and a little bit in Ontario where these things were sold.
Mm-hmm. And one of the things that has happened
with respect to the cyclical vomiting, I mean, we really do need to be careful about, you know, vaping, assuming that when people say they're vaping or using e-cigarettes, that they're talking about vaping nicotine, especially in youth and young adults. They use the term interchangeably. They could be vaping both nicotine and THC. So yes.
And also the extraction of THC to be vaped. Now, I'm not talking about a dry or vaporizer, which is different.
Yeah.
But to vape, you know, you need to get THC oil extraction. That's a butane extraction mechanism, which then creates this oily liquid, which really is not a good idea. I worry about that because that's where you because it's discreet, because you can do it under the, you know, under the covers, you can do it at, you know, all of that, less odor, all of those things. It is pretty problematic. And the thing with inhaling oil is that, you know, especially if it's a micro, you know, it's been aerosolized and it's fine, you don't get sick right away, you don't cough right away, you know, it's a cumulative thing because your lungs have no way of getting rid of it. It then sets up an inflammatory response. So you get sick, you know, not immediately. It's a cumulative effect that happens. And so I really worry that the lack of regulation about this is exposing young people, because they, as you said, Laurie, they use that term interchangeably. When you ask about vaping, it could mean all sorts of things to them. So, okay, moving on. How do we provide effective psychoeducation? Before we move on, actually, there's one more question there that if you saw in the chat. Do you think that the acute respiratory cases we've seen in early 2020 was from vaping or perhaps COVID?
It's a good question, right? But I think the EVALI cases, as Laurie said, actually did quite dramatically seem to stop. I think there was 70-something deaths in the US. Mm-hmm. There was a lot of cases, I think approaching 3,000 EVALI cases. But it is remarkable that they seem to stop quite dramatically, and presumably it was the identification of this vitamin E acetate contaminant, which presumably once removed from the supply chain led to the cases stopping. But I think these cases were distinct from COVID.
So that's a great question. I spoke to one of my colleagues in pediatrics and at Sick Kids, and they basically said, one, first of all, that the first detected cases of COVID happened, say, December-ish of 2019 and coming into 2020, whereas the EVALI were happening before that. And they were, and also when you look at apparently the chest x-rays, they're very different, where the infiltrates happen and the oxygen saturations happen, and you know how they respond, and certainly have other symptoms. So it doesn't seem like that. And the reason for this disappearing, another reason could be, is that everybody is thinking about COVID, and now if anybody goes in with a cough and respiratory failure, nobody's going to think, EVALI when COVID is so rampant. So there's some problems, and I think reporting of that has probably fallen off the radar as well. So I think it's not clear completely. And again, I think comparing carcinogens with cigarette carcinogens, clearly, the exposure per use is exponentially a lot less, I would imagine, with a vaping device than compared to smoking a cigarette, right? Like a pack-a-day cigarettes exposes you to a lot of carcinogens.
Yeah, and again, the actual carcinogenic effects of e-cigarettes, if there are any, it's going to take many, many years for that to show up. There's been some rodent models using e-cig vapor and looking at carcinogenity, and there does seem to be A little bit of evidence there that it does produce DNA oxidation and DNA damage at the chromosomal level, which could potentially lead to cancers. And then there's some evidence, of course, that the trace metals that are found from using e-cig devices may increase the risk of some cancers as well. So, you know, there's emerging evidence, but we can't say for sure what the carcinogenic effects of e-cigarettes are.
So I guess that this is a good segue to the next part, is to what are your recommendations of how do we provide effective psychoeducation on the health effects with our clients? How do you go about it in your clinic, Milan?
I think that's been one of the big problems in this entire area over recent years, is that we answer so many of the specific questions that are posed to us in clinical settings with uncertainty. And it's often uncomfortable, right? But I think our messaging really does need to try and capture that uncertainty in a way that is consumable. And most of our messaging is for those who have got histories of tobacco use and who may have vaped, is making the point, of course, that we are now reasonably certain that vaping is less harmful, but also never failing to make the point that the health effects remain somewhat unknown. So trying to capture the uncertainty is one of our challenges.
Yeah. Well, what I have started doing is you know, and the first part is getting us understanding of where does the patient are? What is the patient's understanding of vaping? Many of our patients, of course, we are biased because we have treatment-seeking smokers who are coming in. You know, we're not seeing people who are there for something else and then they happen to be vaping, I mean, and not treatment-seeking. So I think in a clinical setting, I found just simply asking people what their experience with vaping is, and I get the whole range. Yes, it's great, versus no, it's not, I hate it, or I've tried it, but it's not, you know, I'm a dual user, right? So we're seeing that range. And then we are seeing the person who's saying, look, I feel addicted to this and I need to come off and I'm having a hard time coming off it. So the psychoeducation starts with where's the person's understanding. And I think I go down by, you know, addiction, where they feel loss of control and they're using it in a way that feels compulsive as opposed to, you know, not. And the other education is the health effects as to what we know and what we don't know, both short-term and long-term. And then, you know, where do they want to go with this? And I basically balancing in my mind, of course, is absolute risk, right? So we know from an absolute risk, if you were never a nicotine or tobacco user and you use a vaping device, you're going to have some harm come to you, likely, right? The likelihood, not definitely, but likely. That's the absolute risk. It's there, it's small, but it's going to be there. And long term, we don't know. On the other hand, if you're a dual use, if you're a switcher, like you've given up cigarettes and you've gone to this as an interim, you've substantially reduced your risk if you've done it 100%. So your relative risk has come down, as we think. We don't know for sure, but it seems to have come down. What I'm really concerned about is the people who say, I vape when I can't smoke and I smoke when I, you know, want to. So that dual user is actually having a higher exposure and a higher risk. And they have seem to be, at least in our data, associated with a harder time quitting. So we really talk about that education, that if you are going to use a vaping device, then switch completely. And then we talk about, you know, devices that are not modifiable, that are, you know, that are salts, that are not, you know, and then how to use them in a way that isn't, you know, you're not grazing all day, and that you use it in discrete episodes, and then you look at tapering down that. So, you know, in a way, that's the effective education that we've been trying. And we, you know, we don't have a study to show if it's effective or not, but that's what we do. And Laurie, from your perspective, are there things that you think we are missing that we should be, adding to the education?
Yeah, I mean, I think especially if you're dealing with youth, young adults who are vaping, maybe they've never smoked, is to be clear. Like, I think they see right through kind of the fear mongering and the, it's gonna fry your brain, or you're gonna become addicted, or you're gonna develop P-Valley, or just being clear and straightforward about what is actually known versus what is still, not quite known, what their individual, I think they worry more about their individual risk than they do about, what a study shows or whatever. So, like Peter said, asking them how they're feeling. Are they still in control of their behavior? Do they feel like they can quit at any time, or are they finding that it's kind of overtaking, just kind of overtaking their self-control with respect to vaping? And then you can kind of work with that and say, well, these are all signs of addiction. You may have long-term health effects if you continue to use for many years, and talk about strategies to reduce use or eventually quit.
So Peter, can I just comment on the term dual use, which I think is such an unsatisfactory term, right? It describes such a wide variation in behavior. And I think of a fellow that I saw yesterday in the smoking cessation clinic, who we would categorize as a dual user, a guy in his early 30s who's a mechanic, who has essentially quit his pack-a-day cigarette use, having used a 21 milligram patch, supplemented with quite regular dual use. But he's still technically a dual user, because every weekend when he drinks alcohol, he will smoke a few cigarettes. Mm-hmm. So I think that first of all, the term dual use is difficult, because, as I say, it describes a whole variety of different scenarios. But this is where I struggle with some of these clients. This is a fellow who thinks he's actually had a tremendous success, and he has had a tremendous success. Mm-hmm. He came to us using dual to try and reduce. We added the nicotine patch, and in combination, he's actually done quite well. We're now going to have more discussions around what comes next, but this is the kind of complex client that we're regarding as dual users, of which there are many, many stripes, right?
I mean, I wonder if we need to talk about the term as dual using, so that it's not a stable state, right? It may be just a cross section, they happen to be doing it at the same time, but they may be transitioning either way. And ideally, you want to be getting them transitioning away from cigarettes. And the question is whether their hopes that that'll be accomplished with vaping alone will help them or not, or do you need additional things like adding a patch or something else that can help them leave cigarettes behind? Is correct. But I think, that's part of it, is that we get people into categories, but these are not stable categories, right? I mean, people can transition, and we probably need to say dual using at that time, as opposed to a dual user. So thank you for that. Yeah. So I'm going to move forward, because we've got 4 more themes to cover. So, and we've had a great discussion here. So I'm just going to go to the next one. If I can learn how to operate this one after a year of pandemic. How to quit vaping. Okay. Is there an algorithm to determine NRT dosing? How do you approach cessation for vaping, and how do you stop dual use? We talked a little bit about the dual use, so we'll skip that. And then, of course, the stop one for quitting vaping, we can take care of that one. But let's go with how do you determine the amount of NRT to use for vaping?
Milan, take it away.
Well, first of all, certainly in our clinical setting, there isn't an algorithm. And I think most of us would agree that we don't yet have any kind of evidence-based algorithm to determine how to dose NRT for those who are vaping and want to quit. Our essential principle is start low. So for those who've never used tobacco before, and who are vaping and want help to quit vaping, usually starting out with short-acting NRT and titrating to effect. Seems to be a logical way to approach things. And then if there is heavy use of short-acting NRT, consider the use of a patch. It's easy in tobacco users who've switched to vaping and now want help to quit vaping. I think you can reasonably use their previous tobacco consumption as some kind of guide to where to start with NRT. But long story short, we're making an educated guess at where to start with short acting and then titrating to effect.
Yeah. How I've been approaching it is obviously, first of all, find out if the person is demonstrating any kind of withdrawals from nicotine, if they should, so I go through my withdrawal questionnaire and determine that, because some people may or may not know how much nicotine they're getting. I look at the intervals between vaping. Are they grazing through the day, or are they able to, they just vape on the weekends? So what's their pattern of use? And again, if there's any signs and symptoms of toxicity from vaping, like nicotine toxicity, like do they light it, did they vomit, all those kinds of things. And you're right. If I'm getting somebody who's like they're using nicotine and they're going into withdrawals, and that they're having that first vape hit as soon as they get up, I know that this person is nicotine dependent. I'll be a little bit more sort of patch and start off with a patch if they want nicotine. And my preference is actually to use things that are not dependent on nicotine dosing, such as varenicline or bupropion. But if they do insist on using nicotine, I'll do what you're saying. If I'm not clear, to get a sense of what their short-acting doses might be like. But otherwise, I'll just go with the patch based on what they're saying. I do tend to, if that's the person who's waking up at night to vape and is like having their first sort of hit and vaping session within a few minutes of waking up, and they're saying, listen, I'm going through one of those, my cartridges a day and, or bottles a day, and I'm finishing that off in one day, then I'll say, okay, 21 and some short acting. But otherwise, I tend to be like what you're saying, use a lower dose to get going, because you don't want to make them sick. But in getting an algorithm when you don't have a regulated product, I think is going to be so difficult to figure this out. It's like trying to, both of us come from treating people with other addictions. So when, if people were using heroin on the street, you wouldn't sort of use that. If they said that they use a gram of heroin, you wouldn't use that to calculate the dose of methadone. You would still, because you don't know what the purity is, you don't know what the concentration, you don't know the frequency. So, right? So we would just have to, I think we've used the same principles here.
Of course, the good news is that with methadone, if we overshoot, we kill people, right? With NRT, if we get it wrong, we don't do a terrible degree of damage. So I guess that's one benefit of the situation.
Well, yeah, I guess, but you could make people quite sick, and I try not to do that. So, yeah. Okay. And then the psychosocial interventions, sex differences, gender differences, other pharmacotherapies.
So, I mean, I think it's really important to do some sort of psychosocial or behavioral intervention because, you hear of many people who are able to taper their nicotine dose and actually start vaping zero nicotine liquids, but are they really reducing their harm? They're still vaping regularly. So there is definitely a behavioral component there that needs to be addressed. Mm-hmm. Strategies to do that, I think, would be just your standard behavioral intervention approaches to addiction, I would imagine. Mm-hmm. But
yeah, I mean, we would do that. I mean, it's basically, how do you manage to, deal with situations without needing, a vaping device to augment it or to manage it, and then can use basically modified forms of CBT and relapse prevention to get there. But is there anything else that you've come across or done, Milan, in that space around psychosocial interventions?
One of the things that I think we have forgotten in the discussion about young people who are vaping in schools is the problem that we have really flies against all the advice that we give people with addictions around avoiding triggers, the people, the places, and the things. And maybe we shouldn't be surprised when these 15 and 16-year-olds are having to walk the same corridors with the same people who are all vaping. Don't have a lot of success when we are attempting to reduce or eliminate their nicotine use through vaping. So it's kind of it's an intriguing thought that maybe when we get further down the road and we really start to maybe see more problems with this population with compulsive use, we might need to actually pull them out of the school for a while.
Mm-hmm. And the text messaging, psychosocial supports, and behavioral supports that is emerging from the Truth Initiative seems to have the most evidence right now for vaping. And again, in speaking with Amanda Graham, she really speaks to that, the need for text messaging, because apps don't seem to be cutting it, but the text messaging seems to have a better impact, at least in the US and their data. So that appears to be something that might be more relevant for younger audiences and younger people. So I think it's not just the content, but the modality and the situation, the environment in which people find themselves. And we need to think about young people who are in those environments as well, struggling. Any sex or gender differences that you take or suggest we should take? Either one of you who want to take that question.
Well, there's nothing in the literature with respect to gender differences and vaping cessation. I don't know clinically, Milan, if you've seen a difference.
No, I think we're a long way from understanding these kinds of nuances. But Peter, can I just ask you to just reflect for a moment on your comment about the use of varenicline in those who vape? That's something that we haven't, I think, done at all in our clinical setting. Has that been valuable, and what would be the indication for going with an oral medication for those who are compulsively vaping?
Well, I think it's because of the varenicline being a partial agonist, and that it does affect nicotine intake, and that's what's driving its effectiveness in smoking. That will that be helpful? And I've had a couple of patients where they do report benefit from it, and I think there's some case reports out there as well. So in a sense, because this, you see, when people are quitting smoking, sometimes it's a lot easier because the environment doesn't sort of promote smoking. They're more discrete episodes. People are going out to smoke. Whereas with vaping, you can do it everywhere. Right? It just attaches itself to every behavior, and they can do it discreetly without, without anybody noticing it. So it becomes so automatic so quickly. And so in the couple of cases that I've given, it seems to cut through that and helps them. So that's the rationale. And overall, I mean, if we take a look at the data for smoking cessation, the most, the efficacy is the greatest for either combination NRT or varenicline. So that's my sort of rationale, and overall, it seems to be a way forward. I think we need to do a larger study. We just don't have enough people who are only vaping. And clearly, I don't have any exclusive vapors who've come in with never having smoked before. They're all ex-tobacco smokers, right? I don't think I've seen anybody who's been a pure only vaping and finding themselves addicted to it, at least not clinically.
We've had a small handful of young people who have only vaped, but maybe not surprisingly, they tend to come with a rather appalled and worried parent, and they tend not to stay with us for very long. So the motivation for attending is not usually that of the high school student.
So we've had a couple of high students who come on their own. They don't stay, but we do have a child psychiatrist on our team, Dr. Rodham. And essentially from the child and youth mental health program, the young people who are vaping have a whole host of other conditions, both psychosocial as well as psychiatric conditions and other substances. So it's all within that. It's not a one thing kind of person. Like I have everything else fine in my life and I'm only vaping and I need help for it, right? It's not that kid. Okay, so we talked a little bit about dual users, but will we provide NRT for clients quitting vaping? We will have that discussion. Right now, we have to be a little careful with that because there is no indication for giving NRT to vapors, so officially. So we have to think about how we manage that as we roll out the program. So Laurie, do you want to comment as well on that?
Yeah, I mean, I think just overall, using any smoking cessation medication for vaping cessation is off-label. So right now we wouldn't be able to do that within the confines of STOP. But
yeah.
It's
TBD.
a research question. Yes.
Yes. Okay. How to quit tobacco by vaping. So this is another one. How effective is vaping as a cessation strategy for tobacco use? And what are the pros and cons about this? So maybe we should just talk about the evidence a little bit here.
Yeah, so there's been a couple of very well done clinical trials, one out of England, Peter Hayek and colleagues, and the other one recently published by Mark Eisenberg from McGill University, both showing pretty much a doubling of the quit rate with e-cigarettes, nicotine-containing e-cigarettes compared to either NRT in the UK study or placebo e-cigarettes or just behavioral counseling in the Eisenberg McGill study. So, the evidence is there. Pros and cons, well, I guess it depends on whether you see it as a pro or a con. So, Peter, I think there's some additional slides.
I'm just going to go over to the next one. Do we have it? Yeah.
Right. So this is from the Hayek study. So at 1 year, so people who were randomized to the e-cigarette had an 18% were still abstinent versus 10% who were randomized to NRT. So doubling of the quit, and that's a long-term quit outcome. So that looks really good. But if you go to the next slide, the people who were still abstinent, so in the NRT arm, 9% of them were still on NRT. So they went out and they purchased their own NRT and they were still on NRT. But over half of the people in the e-cigarette arm were still on a nicotine-containing e-cigarette, and another 24% were on a nicotine-free e-cigarette. So, fully 3/4 of the people randomized to the e-cigarette arm were still using an e-cigarette 1 year later, which of course contributed to the abstinence rate. But, is it a pro? It's a pro because they're not smoking. Is it a con because now they're using an e-cigarette over a longer term? It's a point of discussion in the tobacco research community. Some people say it's very much a con, others say it's a pro. So, and I think the other thing that contributed to some of the quit in the NRT arm is that actually 20% of people randomized to the NRT arm were using an e-cigarette at the time of follow-up. So they may have quit on NRT, but then they went on to use an e-cigarette to maintain their quit. So that's the evidence.
Yeah. Okay, okay, now let's go back to, so thank you for that. And I think there's a meta-analysis as well, sort of combining it. One of the caveats that we need to keep in mind, one, in Canada, we do not have an approved, in any kind of way, e-cigarette which has a health claim. Many of the e-cigarette studies have done studies on products which are no longer available, and including even I think the Eisenberg study, halfway through they had to sort of they ran out of supply of the product. So So when we are saying e-cigarettes as a family, you cannot say that the first generation is the same as the second, third, or pod-based systems. And I think we really need to be careful about that when we say about the evidence, right?
Yeah, definitely. So the UK study used a second generation e-cig. Yes, you're right. The Eisenberg study used a first generation e-cig that actually they stopped producing it, so they had to end the trial early. I don't think there's been any trials of salt or pod-based systems for tobacco cessation that I've seen.
Yeah. And again, I think we've just discussed the pros and cons. So Milan, from a clinical perspective, any comments about what you see this as a effective strategy? And for whom would you use it?
Yeah, I mean, the HAJAC study is, the UK HAJAC study is really interesting, right? I mean, clearly, despite the fact that there are some flaws in the study, it suggests that the second generation e-cigarette that they use is more effective than NRT. So that's a study that cannot and should not be ignored. For some populations, the e-cigarette is clearly a tool that we should consider. I absolutely do recommend e-cigarettes in our clinic, but the clinical scenario is usually where there has either been failure of first-line treatments or refusal of first-line treatments.
Yeah.
And I think we are at the point where we could reasonably say that it would be unethical to end the conversation at those first-line treatments and to not say, hey, look, there is something that you could switch to that will almost certainly reduce your personal risk. I think we have to have those conversations. Of course, we then head into really difficult territory, which is, which product shall I use? How much shall I use it? How should I use it? Difficult areas, but I think we're there now.
Yeah, absolutely. I think that's very aligned with how we approach it. Like, as a health professional, we have a duty to provide the known safe and effective treatments first, and as we provide that as the evidence, right, and then have some real clear rationale if you're going outside of that for people who are either unable or unwilling to take the recommended treatments after having an informed discussion of risks and benefits. But again, that it's very hard to stand behind a particular kind of product by name, right? You could say, okay, overall, a closed system which you can add or change things, overall, a high quality system that doesn't, that provides salts, but in this kind of concentration, overall, non-flavored, that kind of vague divide. I mean, it's just bad in this kind of regulatory environment. You can't really say, yeah, you know what, this one has been approved for. Like, I don't have to think twice to say, if I'm going to say, here's a nicotine lozenge, I don't have to worry, oh, you know what, maybe this was made in somebody's confectionery factory with somebody added nicotine to it. I don't know. Whereas I know with the lozenge, it's regular, it's manufactured to a standard, right? So that I'm more confident, and that's what I help my patients understand. I'm way more confident about my recommendations when they are regulated products than something that is just out there as a consumer product where we have a lot of unknowns. So, okay. What about, what are the best recommendations to provide clients who are already vaping as a cessation strategy? What are some of your things you tell them?
Just following on from your previous point, Peter, I will also say, again, anecdotal, but we often have clients for whom we do recommend vaping as the final option because all else has failed. And many of those actually don't find it acceptable. They don't find the vaping enough or acceptable or a good answer. And I suspect what we're looking at there is people with high degrees of addiction to tobacco, for whom really, when you get to vaping as the final option, it's just as poor as the other options as well.
It's true. So I guess in the recommendations to those who are already vaping, as we talked about, is get the safest. I often say get the most expensive product you can buy, and check it out. And I can't recommend a product, but in general, use things which has lower concentration. In general, non-flavored. In general, don't that's product. And the behaviors that go with it is, make it discrete episodes and isolated from all of the behaviors. Don't do any mindless vaping, and switch completely from cigarettes. But I don't know if there are other things that you would add, or Laurie, you would, from a research perspective, add to that sort of recommendation.
Yeah, I would agree with that. I would, if they are using vaping as a smoking cessation strategy, not to just vape when they would have smoked, rather than having vaping become a part of their life where smoking was never a part, right? So using it indoors or at work, or that sort of thing. So making them aware that just because you can do it and it's discrete doesn't mean you should, because it just contributes to the behavioral addiction.
Yeah. Okay, I'm just going to move us ahead because we have a few more minutes. And then the one for youth. Is an algorithm to determine NRT for with youth? I guess this is no. We just went over that with adults. How do you provide effective psychoeducation on vaping with youth?
So Peter, you talked about the program of the Truth Initiative with the text messaging, and the kind of support support through text messaging, and that's for youth seems to be the most effective. I know that OTRU is developing an app-based program as well, so stay tuned for that. So there are things coming out that are Canadian, Ontario specific, to support youth who vape, but they're just not quite out yet, but hopefully in the next couple months.
And I think, again, if in terms of the psychosocial intervention, pharmacological intervention, I think what we are hearing is that, first of all, it needs to be developmentally appropriate, because you're having kids as young as 12 and 13 who are beginning to vape. And it's very different than, a youth who's 18 or 19 who's vaping, which is maybe quite different. Clearly, also pay attention to the pandemic. Pandemic has made it very interesting, because kids could be getting cut off from their supply if they're dependent, for example. And parents many parents are unaware of these new devices that don't create, it's quite discreet. And, we've had lots of anecdotal stories of parents not recognizing that the child is vaping because they think it's a USB stick or something like that, right? They don't recognize it as that. Can be kids are vaping in the bathroom, they're trying to cope with distress. They can be vaping under the covers. So I think those kinds of things, I don't think there's a one-size-fits-all kind of approach anymore. I think young people are quite varied and have, but what is also happening at the same time is, and maybe we are biased, that this is happening in the context of the stresses of young people's lives right now, and including mental health stresses. So my approach has always been is that if a young person is starting to use and getting dependent on this, what else is going on with this young person? And that's often you'll find it's like a red flag. So you have to pay attention to what else is going on in this kid's life, as opposed to only focusing on the vaping. I don't know whether a standalone just vaping without paying attention to that context is going to be helpful. At least in the clinical setting. Maybe at a population level, a text messaging program might be helpful, but clinically, I think we're going to see kids with a lot of issues before we, that's how I think we would need to have an embedded intervention, as opposed to just, set a quit, how much do you vape, set a quit date, stop vaping, go on. There's a lot of comorbidity issues that will be driving this vaping. Any thoughts about that, Laurie? What is your?
Yeah, I mean, I agree. I think, and especially with COVID, I think especially youth, they vape for different reasons. For many of them, it was probably a very social thing to do, and that's gone away. For others, yes, it's to cope with anxiety or symptoms of depression. So I think, yeah, any approach needs to be individualized. You need to really understand the reasons why they're vaping, why they find it helpful or desirable, and yeah, get them to, you know, do the standard, you know, what are the pros and cons of the continued behavior like we do with smoking.
So I think we're going to just jump to the questions in the chat. I don't know if you can see them or you want me to read them out. But I'll just start in case, just while we're waiting. So question is, will vaping become an approved NRT product? And if so, when will that happen? And do you think this would help align these products with tobacco use and help prevent youth uptake? So that's a question that we have there.
Yeah, so until it's fully regulated and then maybe one manufacturer actually gets a approval for medical indication, that's probably not going to happen in Canada.
And I think in the UK, because of the way they've regulated it and brought it out, and it's given us out as part of the NHS, you know, it's the youth vaping doesn't appear to be as bad as it is in North America, where there's been a lot of advertising and is seen as a youth thing. Their messaging has been on point in the sense this is an adult product to quit smoking. So,
yeah, I think that's right. I think the UK had the accidental fortune of positioning vaping as treatment before it caught fire with youth, and I think that has led to a far smaller problem with youth. Of course, they also had the lower concentration devices in Europe due to European legislation with the 20 milligrams per mil versus the 57 that we had with our dual product. Maybe a combination of those factors led to much less youth uptake. But that's not to say that they're out of the woods, right? That's not to say that it couldn't take off in the European Union and the UK.
Okay. And there are a whole bunch of questions that have come up, and in terms of, role of healthcare professionals, should people who vape only get recommendations from, addiction clinics, or who can provide the interventions? And curious as to what your thoughts are about that. Chris Haromi asked that question. Is this everybody's job to get educated and do it and be competent with this uncertainty, or is it only restricted to some healthcare professionals?
Well, you could argue that we don't have healthcare professionals doing a great job with smoking cessation, right? It should be all our jobs, I think, whether it's tobacco or vaping. But I don't think that is the current reality. I think there is uncertainty and confusion, and maybe not surprisingly, based on many of the unanswered questions that we've spoken about today.
Yeah. So I think we're running out of time. We're almost at time. I want to make sure that we just summarize it and say hopefully this was helpful to people to hear how we are approaching this topic with uncertainty, with emerging evidence, with not keeping an open mind to how things will go, and having more of a nuanced discussion. Please keep the keep the questions coming. We will keep trying to figure out answers to them. I know we didn't get to some of the important questions. We'll circulate it amongst ourselves and see if we can get it back by email or through our listserv, post some of those responses, because those are some great questions that we've had. So on behalf of Teach, I want to thank all of you for making the time to be here, both as panelists and presenters, and hand it back to Sophie.
Yes, thank you all so much. I think that was such a great kind of presentation and review of all the questions we've been having. So really appreciate all of you being here today. And then just a quick reminder that a link to the evaluation and post-learning assessment will be sent by email by the end of day tomorrow, and you'll have 1 week to complete that if you'd like a letter of completion. We'll also be circulating again a link to the presentation slides as well as a recording of today's webinar. And then just lastly, our next Teach Educational Rounds webinar will be on treating the complex interplay of anxiety, cannabis, and tobacco, and that will be on April 21st, 2021 from 12 to 1 p.m. with registration coming soon. So thank you again all so much for joining today, both presenters and attendees, and I wish you all a lovely rest of your day. All right.
Thanks, Peter.
Thanks, guys. Well done.
Bye.
Thank you. Bye.
Bye, Milan.
Bye, Milan. Good to